If we're ready for MRD-guided therapy is a very difficult question right now. If the critics would be right to say that we don't have prospective trial that shows that using MRD for guiding therapy is a superior strategy than just treating everybody the same. And that's absolutely true, and that would be the ultimate proof of benefit. However, we make decisions on behalf of our patients or with our patients all the time based on a notion of risk. And it's very clear that MRD is the cleanest and the strongest predictor of risk for future events, progression or death on patients who have received myeloma therapy. The bulk of data being developed starts to inform us how the outcomes of the patients are given that they reach or do not reach MRD negativity. So I think that is going to start influence our decisions and factoring that important prognostic piece in deciding what patients should be on therapy for longer or versus not, or a patient needs additional therapy for not. The next chapter that I think is currently being written is trials that enroll patients up on at a certain course of their therapy based on their MRD status, and these are going to answer very specific questions, like it's okay to deescalate therapy on patients who are sustained MRD negative response, or is there a value for escalating therapy on patients who remain MRD positive, for example, after transplant. Until this data is out, I think we all should use MRD like any other prognostic tool, and we adapt therapy all the time based on the depth of response assessed by protein, and on other elements of risk, such as sometimes age and sometimes cytogenetic risk, and I think the same treatment should be given to MRD.